Good evening. Thank you very much for joining us. So we're here to look at the proposals for Your Care, Your Views. And tonight we are particularly looking at respiratory medicine. I have a couple of guests with me and they will introduce themselves when they speak to you. So tonight we are using Zoom as we have been for all the sessions that we've been on so far, and we do ask you to stay on mute, so you have been muted, and then not to use your camera please, as this just helps us with bandwidth. The way to ask questions is to submit them via the chat function, and there will be plenty of time for you to ask questions at the end of the presentation. We are recording the session and it will be uploaded on our YouTube channel, as are all the other sessions that we've been running so far. And thank you if you've been watching those. They have had quite a number of views. So a little bit of setting out the aims of the session. It is to explain the proposals that have been developed to deliver new services from our 3 hospital sites, to talk to you a little bit about the engagement, and as I said, to give you an opportunity to ask questions. I'm sure you're familiar with the background because I've seen the names of the audience who are out there, so I do know that you are familiar with this, but for anyone watching this back, I should just repeat that we have been working with our commissioners, that's Herts Valley's Clinical Commissioning Group, for some time now, many years, to secure significant funding for major redevelopment of our 3 hospitals. So that's Watford General, St Albans City Hospital and Hemel Hempstead Hospital. In September 2019, Prime Minister Boris Johnson came to visit us at the Watford site and gave us the good news that we were in the Health Infrastructure Plan. We sometimes call that HIP or HIP 1 because we're in the first wave. At that time, there were 6 trusts in HIP 1. The programme is now known as the New Hospital Programme, and there are 8 frontrunner trusts, and we're delighted to still be in that number. Of course, it's not quite as easy as just the Prime Minister coming onto the site and saying that money is going to be awarded. We have to work really hard to get that funding, and what we're doing at the moment is working through our outline business case. And that means that we are pulling together lots of facts and figures. We're looking at our buildings, we're looking at our services, we're looking at future population growth, and we put that into our application, and that goes to our regulators, of whom there are many, or at least it feels like that sometimes. So we have NHS Improvement, NHS England, the Department of Health and Social Care, and Her Majesty's Treasury. And our application, our outline business case, has to show that it is good value for money and that it can be delivered by 2025 or soon after. And if you've been to any of our 3 sites, you will understand the urgency, because although we hope that your care has been excellent, we are pretty sure that your view is the same as ours, in that our estate really needs some urgent attention. So Your Care, Your Views, you may remember Your Care, Your Future. It's no coincidence that Your Care, Your Views has a similar name to Your Care, Your Future. That was an engagement programme from some years ago, and some of the ethos behind Your Care, Your Future really is carried through into Your Care, Your Views, particularly around providing care closer to where you live and looking at preventative medicine. And you'll hear a little bit more about that, particularly when Dr. Barlow talks about avoiding hospital admissions and how important that is. So we have 4 documents, which we hope you might find time to have a look at. The strategy document is really where it all begins, and I'm very pleased that we have our Director of Strategy with us tonight, so she will be able to give you lots of insight into that. So the strategy document has a kind of pragmatic partner, the clinical brief, and it's the clinical brief that will give you a lot of detail about where we think services will be provided from. And then there are 2 engagement documents, one longer and a slightly shorter one, a summary document, which just give you a broad overview. And we're really asking that people do read these before completing our survey. So a couple of sort of driving themes behind our proposals, and one of them is about, well, we say three's company because we know that the phrase is two's company, three's a crowd, but we actually think our three hospitals can work together really well. And what we want to do through our proposals is to further enhance each hospital's unique purpose. So really to hone in on what makes that hospital special and what range of services it will deliver. So for Watford, that will remain as the site for emergency, specialist and complex care. St Albans will be the site where we deliver planned care, planned cancer care and an urgent care service. And the asterisk there is just to recognise the fact that the minor injuries unit is currently closed, but we look forward to providing an urgent care service from that centre in the future. Hemel Hempstead we see as being the site for urgent and planned medical care and long-term conditions. And urgent care services and some outpatient services will be provided at all sites. And I think when looking at the three different hospitals here and the different offer, it's really important, and something that we need to tell you is that your local hospital might not always be the best hospital for you to go to. So you might live in St Albans, but if you have a long-term condition, it is very likely that the best place for you to go is Hemel Hempstead. And if you live in Hemel Hempstead and you are having planned surgery, it is very likely that that surgery will be delivered at St Albans City Hospital. When talking to our clinicians about our proposals, and these are clinically led, they're not cooked up by managers, these are based on clinical views from people who want the best outcomes for their patients. So it's really important that we listen to our clinicians when we are pulling together proposals. And one thing that came through loud and clear is that they are stretched quite thinly in many cases across all three sites. So we have tended over the years to deliver as many of our services as we can across all three sites. And sometimes that has been to the detriment of the quality of the service and also for the experience of our staff. So by having our staff in greater numbers grouped together around the specialty that they deliver, we think we can provide a better patient experience, but also a better working experience for our staff. Our junior staff can have senior staff working alongside them. They can quickly get second opinions when needed. Their learning and development will be boosted by being in larger teams, and also it will help us make really good use of our diagnostic equipment. Also, when we stretch our teams thinly across our sites, we really do run the risk of cancellations. So by having larger numbers of our staff together, we can reduce the risk of cancelling appointments. Importantly, digital underlies all of this. So digital and diagnostic, they're two enablers. And the digital transformation, which Dr. Barlow will also talk about a little bit, because he can talk better than I can about the virtual COVID hospital, which has really relied on digital input. But digital is crucial for us. It's helping us communicate differently with our patients, to manage online consultations, which can save an awful amount of time. And also we can look after people in their own homes or in other settings other than bringing them into hospital. Another part of digital transformation is our electronic patient record, EPR, and that work has started. Our staff are already getting a glimpse of what it can deliver. And I have to say, there is a high degree of excitement about moving away from paper, about increased accuracy, about being able to see your health details with your permission from other organisations, and for other organisations who are looking after you to also see your information from this organisation, so to get a fuller picture of your care. Feedback so far is that patients have been, on the whole, very positive about virtual appointments. They have lots of benefits, not just in terms of reducing the need to travel and park and prepare to come to a hospital site, but also other family members can join on to the same appointment, and that can help patients with making sure they absorb all the information and ask all the right questions. So diagnostics is the other enabler that's so important to our proposals, and we really want to speed up the diagnosis, so to reduce the time it takes from whatever procedure you've had, diagnostic procedure, to you getting the result. And then we want to move swiftly on to, within the same appointment, to a result given to you, and then an idea of what the next stage of your treatment is. So really to re-engineer where the diagnostic process fits within your patient journey, which is the phrase we use, and also to think about how quickly we can get results. And this will require quite a significant investment across all 3 sites in our diagnostic facilities. And we did run a session on diagnostics on, I think it was probably yesterday, and that will be uploaded. So it has a lot of extra details, so plenty of information out there on our diagnostics. And you can just see a little bit more detail on this slide. So I believe now I am handing over to Dr. Andrew Barlow. He's going to introduce himself and take you through the next a few slides. Thank you.
Thank you, Louise, and thank you for the reminder to introduce myself. My name's Andy Barlow. I'm Divisional Director for Medicine and have been for about 2 years now. I've been a consultant in the Trust for 16 years on May the 1st, and I've been a respiratory consultant for that long. When I first joined 16 years ago, I was single-handed at Watford. It's almost impossible to believe that, looking at the complex and big department we have now supporting both acute and long-term conditions across all 3 sites. Second thing I wanted to say was that these proposals are genuinely a clinically driven vision. We've had multiple meetings over the last 18 months, 2 years, discussing what a new hospital might look like and what would work best for patients. And I can guarantee you that at the heart of every conversation we've had with clinicians around the room, the patients have been at the center of the discussion always. And these are proposals for 3 real hospitals. And I mean that in its most genuine sense. And I think that people might believe that a hospital without an A&E, for example, isn't a real hospital. But I can come back and discuss that a little bit later if we have time. Louise will be fielding the questions. So the proposals for Hemel Hempstead Hospital really are about co-locating specialties together so that we can really develop and begin to develop what might be viewed as a one-stop shop for patients with long-term conditions. So the vision here is that rather than having 2, 3 or 4 visits to maybe different hospitals as it is now, you can come up to Hemel Hempstead and have all your appropriate diagnostics. And we're delighted to see that Hemel will be supported by a complex array of imaging, and the imaging suite will include MRI, CT, DEXA scans, as well as plain radiology and ultrasound. So you'll have your tests, if necessary, simple biopsies, lung function, for example. Then you'll be able to access the relevant specialists for your condition. And I deliberately use that term in the plural because it may well be that your condition requires input from a number of different specialists and professionals. And the idea is that we pull all of these people into one place where possible, so that it makes it easier for you and you get all the answers, and if possible, all the treatments you require at one visit. And that's exactly what we're driving for. Next slide, please. So with the developments at Hemel Hempstead Hospital, we'll be moving cardiology, dermatology, diabetes and endocrinology together with rheumatology to Hemel Hempstead and co-locate these major specialties that really are the beating heart of long-term conditions. There may be a few patients currently looked after at Watford for dermatology that will come across to Hemel Hempstead. Diabetes will have a specialist clinical hub, and I think in terms of one-stop model, diabetes is probably the best example of pulling together numerous different specialties in one place for the benefit of the patients. And in fact, they've been working very much toward a one-stop model for the last couple of years. The other important point to stress here is that we consider ourselves a family in a larger community of healthcare providers, and we don't work in isolation. And where required and where necessary, we will be integrating primary care colleagues, community trusts, mental health trusts, and social care partners into Hemel Hempstead to help with the care of patients with long-term conditions. Next slide, please. So respiratory services are currently provided at 3 sites, and we will, where possible, aim to provide elective outpatient and diagnostic services at Hemel Hempstead. As I mentioned, 16 years ago, there was 1 consultant at Watford and 2 consultants at Hemel, and we're in a very different position now. And at that time, they were distinct and separate hospitals, but now we're one big team. And the range of services that we provide at Hemel Hempstead has grown. And the idea is that we're going to be co-locating our outpatient services at Hemel Hempstead very close and adjacent to the required diagnostics that we rely on a regular basis. So that will be complex lung function services, and I can talk about that a bit more if required, Louise, as well as radiology. And many of you will know that respiratory consultants are in fact frustrated radiologists, and over the last 10-15 years, we're heavily reliant on plain X-rays, but more specifically cross-sectional imaging like CT scans, and we're delighted to be co-located with the diagnostics that we're going to require. And so, if you will, you might come up to us for a consultation or a visit. You will have your required imaging, and you will then go and see the specialist to discuss the results and necessary treatments. And that's the vision for the Hemel Hempstead site. Next slide, please. So very much we see the Hemel SACH sites as offering complementary services. And as Louise has already mentioned, St Albans is very much badged as the surgical centre, and with a very much a cancer diagnostics flavour. But that's not to say that cancer work won't be done at Hemel Hempstead. And actually, if you look at the cancer types, lung and dermatology definitely have an emphasis where there will be work provided at Hemel Hempstead for those types of cancers. The other more surgical slanted cancers, bowel, breast, and urology, are likely to be at St Albans. Endoscopy facilities are the foundation of much of the diagnostic work that my department does, but also gastroenterology. It is impossible to expand the endoscopy facilities at Hemel, and so we've taken the decision to move that across to St Albans, and I believe double the size of the endoscopy unit that we propose to develop at St Albans. And we believe this is a significant and promising step for those services. Yeah, next slide. This is Dr. Ballara, who's a rheumatologist and good colleague, and he's clinical director for specialist medicine. Can you hear me?
We've just, oh yes, yeah, we just lost you there. We lost you at Clinical Director for Specialist Medicine.
Thank you. My screen was idle and it logged itself off, but apologies for that. So Sandeep and I have talked a lot about the relative benefits of separating services out like this. So you have an acute site and a site that really focuses on and becomes a real specialist centre for elective work and chronic conditions. And he and I have really discussed this in length. And why would you as a patient or as a family want to come up to an acute site with all the chaos that surrounds that, where you could go to a much calmer environment and get your appropriate diagnostics and care there. And for us, I think this is a win-win for both staff and patients. And so we're very much behind this separation of purpose at the 3 sites. Next slide, please. As I've mentioned, St Albans, which already has a strong and significant emphasis on the delivery of elective surgery, will remain as such, but will look to expand the range and portfolio of surgical services offered there, with the intention of stripping as much as we can from the acute Watford site and offload that where possible. St Albans will of course be serviced and supported by the full range of appropriate diagnostics, including MRI and CT as they are in Hemel Hempstead. And as I've already mentioned, we plan to locate a new expanded endoscopy unit to support cancer care and other specialties at the St Albans site. St Albans will also host gastroenterology services and hepatology services. It will also have an urgent care service, and where possible, we will take that principle and vision of one-stop clinics and apply it on the St Albans site as well as the Hemel site. But as I said before, St Albans will have a very definite surgery and cancer emphasis to the work that's performed there. This is Mr. Banks, one of my colleagues and a consultant neurologist. And I think really what he's trying to get across here, and he and I have talked many times about this, is really just trying to simplify the service. It can't be easy for a patient if you have a condition which is worrying enough, if it's a potential cancer, and then you're called up for you get 3 or 4 different envelopes through the door. One's for an appointment in one hospital, one's for a biopsy in another, one's for some imaging in a separate site entirely. And really, what we're trying to do here is clean that all up and give you all of those required interventions in one place, and if possible, on one day. And I think that everybody will win as a result of that. Next slide, please. Watford will remain the acute site. It'll have an extended and improved emergency front door facility. It will continue to have an urgent treatment centre. The emergency department is already being expanded, but we desperately need to see better and larger assessment areas for the benefit of patients. We will continue to do high-risk surgery there and non-elective emergency surgery there. And of course, Watford will be supported by a critical care department, which has been the bedrock of our fight against COVID over the last 12 months. Of course, it will have complex diagnostics like the other 2 sites. And of course, we will continue to try and apply the one-stop model at St Albans if possible. There is a new planned multi-storey car park there, which will benefit staff and patients alike. I know what it's like running a respiratory clinic at Watford. You can tell when your patients arrive outside the door before you even open the door, because if they've had to walk up from the bottom car park, it really is a challenge for respiratory patients, and I think the new car parks will help with that. We have a range of potential new services which are being planned or considered, and those include inpatient neurology, for example, and an expansion of our chemotherapy offering, which is currently just day case to inpatient as well. Women's and Children's Services will, of course, remain at Watford, where they're currently hosted. Next slide, please. So this is a subject very close to my heart. Colleague of mine and I, one Monday evening, one wet Monday evening in March, sat down in the evening and with our heads in our hands and said, look, you know, we've seen the data, we've seen all the newscasts, we've spoken with colleagues in Europe. What are we going to do to try and look after patients safely? But surely we don't need to admit them all. And that's when the COVID virtual hospital was developed, and that was on the 9th of March, and we admitted our first patient on the 15th. And if there were any good things about the COVID era, that was the ability all of a sudden to strip away the red tape, and as clinicians and managers together, be really agile and put services together to look after our patients. So the COVID virtual hospital developed and evolved rapidly over the next few months. And effectively, it was a service that if you were a patient at the front door of the hospital, but we felt you didn't need to be admitted, we admitted you, if you like, to a virtual hospital, a virtual ward, but you were actually at home. But we used technology, digital technology, as Louise mentioned, to keep you monitored and keep you safe. Initially, that monitoring was quite crude in the form of many of these little probes that people put on their fingers called oximeters. But a more sophisticated measuring systems came through in due course, and we were able to have a real two-way dialogue with patients whilst they are at home, with an ability for them to upload data, how they're feeling, symptoms, and objective measurements of how they were. I think to date now we've processed or put through in excess of 4,500 patients through our COVID virtual hospital. It's been the busiest COVID hospital, virtual hospital in the country, and you know we're really thrilled that, as it turned out, NHS England used our model to push the national strategy for COVID virtual hospitals, which is now being rolled out everywhere. And it's nice to know that we started something good at Watford, which is now being copied across the country. Next slide, please. But we've learned a lot from that, and on the principle of adapt, adopt, abandon, we're looking to do things in different ways now. And what if we could take that technology and learning that has kept patients safe, it has kept patients out of hospital, and apply it to other conditions, other long-term conditions. I'm delighted to say that we're in quite an advanced position to look at how we're going to use it for two other significant health conditions: heart failure and chronic obstructive pulmonary disease, COPD. And we very much hope that in the early summer this year, we will be rolling out a program exactly like the COVID virtual hospital, which will take patients from the front door, but also facilitate rapid and early discharge, supported by technology, and if required, also integrating into the pathway our nursing colleagues from the community services that we have out there. So this is really throwing away the old model of a hospital, where you have bricks and mortar of an acute hospital, and then you have GPs and you have community nurses, and we're saying, okay, well look, let's just reimagine it. What if we can provide really superb care, but unrestrained by that old mantra and those old ways of working? And we really believe this is the future of healthcare, where we only bring patients to an acute site if we absolutely have to. And to be perfectly honest, you know, we really believe that an admission at an acute site is a health crisis, and it represents probably a failure of the system somewhere along the line, or multiple points along the line. And we what we aim to do is to provide the care at the elective sites like Hemel Hempstead, so that the patients never have to get to Watford, because it is a failure if you do. Next slide, please. So what I was going to say about this slide is that, and you know, it does bring a frog to my throat. Actually, it's the 12-month anniversary of lockdown, and it's been an incredible year, and incredibly hard-wearing on, you know, what I consider a family of friends and colleagues at Watford that have seen some of the worst that the health crisis has had to offer, and we've been uniquely affected in the region, and you know, that's just bad luck. But I'm pleased to be able to stand shoulder to shoulder with amazing nurses like Vicky. And today, you know, I think we just remember how brilliant colleagues have been across the patch, and also remember some of the colleagues that we've lost over the last 12 months. Okay, thanks.
Thank you, Andy. A little bit modest there, because Andy has actually been asked to take on the regional role for teaching other hospitals in our region about how to adapt to a virtual model. And the other doctor involved, Dr. Matthew Knight, was awarded an MBE for his work on the virtual hospital. So just to give you a flavour of how highly that model is thought of. So yes, I'm sure if I say thank you, I'm saying thank you on behalf of 4,000 patients who've had their care delivered in that way. But my slide here is just to explain to you the engagement programme. We're coming to the end of our first period of public engagement. We will do another after the local elections. So if we haven't got out to your group, we can make sure that we can do that after the local elections. So we know we have some gaps to fill, and we will also use that second period of engagement to clarify. So if the feedback tells us that we have confused you or we haven't been clear enough, then we will come back out and we will give further information where we can. And we will review what we hear from the first wave, and that will go to our trust board in May. And then from the second public engagement, all of that feedback will be compiled into a report which our trust board will consider when they make decisions and when they look at the clinical brief, and later on in the year when they make a decision around the final preferred option. So wanted to just say something very quick about the survey. It has been commissioned externally, and the company who are producing that for us are called Timus. Their details are there, and they will also do the analysis for us. So although we might like to think that we're good at providing clinical services, when it comes to devising surveys, that's not really our strong suit. So we've had some expert help on that particular part of our engagement. We do hope that you have looked at the website, or that you will look at the website. So although we stopped doing our public engagement in terms of meetings on Wednesday, tomorrow, all of the information that we've been providing through these sessions and through our documents is available on the website. So although we stopped talking to you, that doesn't mean that you can stop finding out more about our proposals. In terms of the survey, we are very much hoping that we can extend the deadline to Sunday at midnight, but more news on that will come tomorrow. And as I say, there are links there, and we would really like you to read up a little bit more about what you've heard from Andy tonight, and particularly the strategy document, as we have Claire with us, is something that we could pick up some questions on tonight if anyone has any around that. So moving on to questions, and I think also we have the QR code if you use these things for your to hover your mobile phone over if you want to get a link straight to our survey. So I'm going to start with a question which I think, Claire, you might pick up the first part of the answer, and then possibly we will go to Andy. So just to refresh my memory, the question was about working with Hertfordshire Partnership Foundation Trust We love our jargon in the NHS and we normally call them Hearts Parts, but we will try to call them Hertfordshire Partnership Foundation Trust. They are the mental health organisation. And the question is, will HPFT have a service based in Hemel Hempstead Hospital to support patients with long-term conditions? So Claire, if I can ask you to start.
Thank you. So we absolutely recognise that for people with long-term conditions, that can cause a lot of anxiety and depression and other issues that affect their mental health and well-being. So we absolutely, as part of our future clinical model, are working with our Hertfordshire Partnership Foundation Trust to make sure that we have got that support available. So we've done that in the first instance with our diabetes service, so that we have an integrated diabetes service looking after some of our more challenged, more complex diabetes patients. And that has HPFT as one of the partners within that service so that they're able to provide that support. It's been very successful. It's also given us some learning in terms of other ways that we might want to provide people with support. There are lots of things other than just anxiety and depression where we think that could be beneficial. So we absolutely would see as part of our overall care model that would have integrated mental health support within it, whether that's physically provided in Hemel or whether that's available through online or other means, because obviously a lot of mental health support can be delivered in different through different models. That we'll see, but yes, we would absolutely expect that to be part of the long-term conditions model that we're looking at for Hemel.
Thank you. Andy, did you want to say anything about working with other organisations?
No, only to really endorse the principle. I think we're all humble enough to realise that you can't solve a clinical problem by being a doctor or a nurse or a clinical psychologist or a psychiatrist or a GP. You actually need a broad church of interests and skills, and so as a principle, we would want and need the hearts and minds of patients looked after just as much as their bodies, and it actually is a significant gap in some of the care models that we currently operate, and so the move and the development is an opportunity to right that wrong.
Thank you. And in particular, the virtual model has quite a heavy input, doesn't it, from Hertfordshire Community Trust. So could you maybe just expand a little bit on what the nursing staff and the community staff bring to that model and how we all link together to provide the care around the patient?
Yeah, I mean, I can give you an example with the COVID virtual hospital. Whilst the input initially when the patient's acutely unwell is probably more light touch from that team, we have a follow-up program which actually includes significant focus on the patient's anxiety and mental health, using validated scores, and then where we're finding problems, we move those patients to appropriate professionals that can help. So yes, it's an integral part of the clinical model. Thank
you. Andy, I'm going to stick with you and the virtual COVID hospital, which has obviously been of huge interest to people this evening. And the question I want to ask is whether the model has placed additional demands on community services and family carers, and if so, how has that been resourced? That's a really good question, actually. What we've tried to do is be sympathetic to families in our decision making. So an example of that might be that when we're planning a discharge, we would take into account the views of the family, and if they weren't ready or they weren't configured to take a patient that wasn't quite 100%, then we would not have discharged them onto the virtual ward. So it really was a selected group of patients that were appropriate for home care, and we were very mindful not to excessively burden relatives that might be primary carers. That said, I think it's worth saying that
The alternative is that the patient is admitted to hospital, and the enforced distance and inability to visit has actually caused separate harm in its own right. So actually keeping the family together has its benefits. Thank
you. I'm going to keep going with virtual hospital. Andy, I know there's some figures. I think was it the BMJ or thorax? So a clinical journal has recently published some statistics about outcomes, and I think that might be worth highlighting, because I've had a question about whether or not we've compared measures of success in this model with a more traditional model. Is there something you can say about that, please?
Yeah, we're quite early in our analysis, but there's some interesting trends and themes coming through. The BMJ published a national paper back in October, November, and it implied that if they looked at all the patients admitted with COVID and then tracked them for 90 days to see what happened to them. And according to this paper, 1 in 3 patients were readmitted within that 90 days, so just over 30%. Now, we looked at our readmission data, both in wave 1 and wave 2. And in wave 1, it was about just over 8%. And in wave 2, actually, it was actually under 2%. So we think that there's something about that continued contact with the specialist and the community nursing teams caring for a patient for 14 days on a virtual hospital at home, but with access to specialists on a daily basis, has meant that we've alleviated anxieties that might have driven future admissions, and we've identified problems because of the ongoing contact. And by identifying the problems early, we've prevented potential admissions that would have happened. So we're really excited by this signal, and we think that we can realize those benefits in other conditions as well. COPD, for example, has a similar readmission rate at 90 days. And so we're really keen to see what impact the readmission rates are if we can get COPD onto a virtual domain. Does that answer your question?
Yeah, no, that was great. That was great. I mean, it is weighing up very positively, isn't it, against the hospital-based model? So that's really good news. Okay, so Claire, I'm going to ask a question to you now, which is about if you know it. If not, we might pass back to Andy. But it's about geriatricians and frailty consultants, and whether or not they're going to be based at Hemel Hempstead Hospital, and a little bit about the frailty assessment unit, if you can talk to that, please.
I might have to pass the frailty assessment unit to Andy, I'm afraid, but certainly in terms of the first part of the question, then yes, absolutely. Obviously, a lot of the people who have got long-term conditions are also frail older people, so we would see that as a really core part of the model of care for Hemel Hempstead. So yes, we will absolutely have care of the elderly frailty consultants on site, as well as other specialists, as Andy said, the multidisciplinary team that would need to be supporting those. And we also anticipate that some of the other services we're looking at, or we're thinking about in terms of Hemel. So we're in early sort of looking at how we might support people who might need things like infusions or some form of observations, and how we can use some of the space at Hemel to do some of that.
Thank you. Did you want to add, Andy, to that?
Yeah, no, I can add a bit more detail. So part of the frailty model has to be in the acute hospital because some of the patients that are admitted and brought to hospital are necessarily in an older age bracket and or frail. So we do have frailty integrated into our new emergency assessment unit, and that is their home at the present time. And that's an appropriate place at the acute front end of the hospital. But I think the plan is longer term to develop a model where we have a collaboration with primary care and community services, so that our care of the elderly patients are looked after in the community, but with much greater scrutiny, so that they have routine and regular reviews of all their health conditions, their medicines, and clinical assessments, but in that way we will hopefully identify problems earlier. And if we do pick up a problem, then it is anticipated we will bring them to Hemel Hempstead primarily, and that is where majority of the specialists that have that look after the long-term conditions these patients have, rheumatology, respiratory, cardiology, will all be co-located there. And so the idea is that we are putting there in one place, so that if we do need to bring a frail elderly person to hospital, which we recognise is difficult, then we will minimise the number of visits and try and get as many, if not all, of the specialists at them and helping to solve their problems in that one visit.
Thank you, excellent. Okay, I've got a couple of questions about the building, which says, can you confirm that some of the blocks are 11 stories high? I can't, and I don't think we're anywhere close to having that level of detail, but on that I can say that the consultation, which is a planning consultation around the buildings at Watford General, opens on the 26th, so opens on Friday, and that will run for, I haven't got the close dates, but there will be further information available tomorrow about the consultation period on the outline planning application. So that will have more detailed drawings on, but I don't think we are yet in the position that we can count the stories, and that will remain as a fixed point. We are working through all that detail to understand the schedule of accommodation and how the buildings could look, but I don't know that we have enough certainty at this point to count the stories. But I think the best place to go for all of that information is to look at the outline planning application and the consultation around that launches on Friday. This your care, your views is really about the services. And so the point of having clinical staff with us and Claire with us is to talk to you tonight about the proposals for our services. So that is really why we're here tonight. And so I will prioritise questions that are about the clinical services first. And Andy, there is another one for you on the COVID virtual hospital about the equipment that Alex is one of our physiologists in the team, and it says, are you saying the kit that Alex uses is only available in Watford? As far as I know, Alex works across both sites. Does he?
Yeah, he does. I can answer that. So we have a lung function lab both at Hemel Hempstead and at Watford, and it's very much intended that continues. Hemel Hempstead will be offering full lung function in addition to some more limited exercise physiology. There's an exercise bike room, and we can do exercise-induced asthma testing, for example. And the full range will be offered there at Hemel Hempstead. We'll need the full range there. There's no way we can run a proper diagnostic service allied to an outpatient service without that there. Equally, we need some of the services at the acute site, and there are in fact some exercise tests that you actually need a resuscitation team on site for, and for that reason we can only run those at Watford. Very much along the lines that some of the cardiology tests need the same backup support. So at Watford we have full lung function, but full cardiopulmonary exercise testing as well.
Okay,
very much two-site model for a complex lung function lab.
Sure. So new equipment will also be provided in Hemel Hempstead,
as I understand it. Yeah.
Yeah. Okay. Claire, can I ask you a question about patients being stepped down? And the questioner wants to know about patients being stepped down to vacant beds in care homes. Do you know if this is something that is happening? And the second part of that question is this safe during the times of a pandemic? So two-part question, one about patients being stepped down to vacant beds in care homes, and then about safety. But perhaps if you could also address the question about intermediate beds, because of course that's not something that we provide. So if you can try and wrap those up, that would be great.
I will, yeah, I will do my best. And again, Andy might know a bit more than I do. So it's not an area that I'm closely involved with. So if you leave aside COVID, and if we were talking about normal times, then yes, there would absolutely be some patients who would go, if they were already in a care home, would go back to their care home after they've been in the acute hospital, or if their needs were such that they needed to go into a care home, would go there from our hospital. We have changed arrangements during the COVID pandemic to move to what's called a discharge to assess model. So previously, if somebody needed an assessment of their future needs done, that would happen within the hospital before they went home. But there are a lot of disadvantages of that. It can actually be much more effective to assess somebody in their home environment or the care home that they live in, so that you can really understand what do they need to do on a daily basis, what matters, what functions they need to have to be able to operate safely. And so actually the discharge to assess arrangements, where people are given full support while that assessment is done and then a care package is put in place, has been one of the positive, again, changes. There are some things we'll need to adapt on the longer term, but as a principle that you should be assessed in your own home environment, that's the right thing to do. During the COVID period, and this is where I'm Andy may know better than me, I don't think we have been discharging COVID positive people directly into care homes. I think that has been either they've gone into designated COVID care homes or they've gone into intermediate care beds, is my understanding. But Andy, please correct me if I'm wrong on that. Obviously, practice changed, I think, during in the pandemic as people understood more about what some of the issues were. But I think we're very conscious of the risks and issues around care homes, and it's I mean, we work very closely with the Hertfordshire County Council on and Hertfordshire the County Council are the ones that work closest with the care homes and support them, so I'm probably a better place to know than me. In terms of intermediate care beds, as you say, we don't provide those. Those are provided by Central London Community Healthcare, which is the adult community provider for our part of Hertfordshire. So where appropriate and where people need to step down into an intermediate care bed, that happens absolutely at the moment. They are reviewing their provision and both the support they provide to people in their own homes and the number and range of intermediate care beds they have, and they are planning a consultation of their own later in the year, I think over the summer, so that they can get have some public involvement and engagement into their plans for what they want to do in terms of numbers and placements of intermediate care beds.
Thank you. I don't know if either of you know questions about the Hemel Hempstead site, or even if we have that amount of detail at this stage, but the question is, do you know which of the existing buildings will be used at Hemel Hempstead Hospital?
I hesitate to go off piste and so talk about anything structural, but I believe it's the Verulam wing is the designated building for all of the services at Hemel. And to be honest, knowing the Hemel site, actually, if you can concentrate it all in that one more modern building that's obviously going to have a significant amount of work done to it, then I think that's to the benefit of the patient who would otherwise have to walk across quite a hilly and large site.
Thank you, Andy. I should just say that the planning consultation that I talked about is just Watford General, because that has a far longer planning application process, and once work is sufficiently underway on that, then our architects will return to work on Hemel Hempstead and St Albans. And that doesn't mean that the work will be done to our hospitals in that order. So it is very possible that work will be done to Hemel Hempstead and St Albans before Watford is completed. But in terms of drawing up the detailed plans, as I said, because of the length of the application process and the approval, then that is where the focus of the architect's time is at the moment. But we will soon look in much more detail at the Hemel Hempstead and Watford sites. I've been asked, Andy, about respiratory care and how it integrates with community respiratory care. And I know that's something you've done a huge piece of work on. So perhaps if you could spend a couple of minutes just explaining how acute and community respiratory care work. Thank you.
Yeah, actually, I'm going to start by tearing up that model. You won't be surprised to hear that I think people need to reimagine this. And I think that if we're trapped in old ways of thinking, community hospital, you actually end up forgetting about the patient and you focus more about the institutions trying to deliver the care. So the way I want to answer that is to say, look, the vision that we're looking to put together for the future for respiratory medicine is one where the patient owns the journey, the patient understands what's happening to them, and whatever they need, that will be delivered to them in the most appropriate place by the most appropriate person. But where the clinical governance and the complex understanding of the illnesses and how they interplay with everything else, that will obviously rest with the specialist. But it's an integrated model where everybody's got a role to play, not just the consultants, specialist nurses, and all the other allied medical specialties. And that's the best way I can answer that question, Louise. I'm moving away from getting trapped into these old ways of thinking. It's very much about the patient and where they need the care and the best place for that.
Thank you. Okay, a couple of slightly different questions now about the new hospital programme. So I know that there was that Natalie Forrest was speaking today. I forget her job title, but she's leading the new hospital programme. I might just have promoted her. She's a very important person in the new hospital programme, is what I will say. And she has talked about the 8 frontrunner trusts, of which we're one. And she hasn't given any indication of which order. And I think the question is asking for our response to that. And we don't expect at this stage for there to be an order of who gets how much money, when, and which organisation goes first. I can tell you that we are working our socks off to be at the front of the queue, and we really want to secure all the money that we think is necessary for our plans. So that's the focus of our work.
And maybe if I just
Claire, go.
I was just going to add to that. So certainly in no conversation that I've ever been involved with has there been a concept that they're doing anything other than trying to get all 8 frontrunner trusts built as quickly as possible. So I don't think that there is any expectation that there's a competition between those 8 organisations. I think the intention of the programme is to get as many hospitals built as quickly as possible. Though, like you say, we will always do our best to make sure that we're one of the earliest and the quickest.
And there has been no announcement yet, because we are all roughly in the same, we're all progressing through the outline business case stage. So we couldn't possibly know until we've submitted our outline business case. So we're some months off from really understanding a bit more about that. And the second part of that question is, if you were given more breathing space, would you look again at clear sites? And in all the discussions that I've heard around the trust board, and also with the commissioners and with our regulators, actually, we are all very committed to our 3-site model. We do believe it is the smoothest route to being able to deliver new and refurbished facilities. This is set out in previous board papers, also in a paper we took to Hertfordshire County Council, to their topic group in February, when we were talking through the rationale for our 3 sites. And as I said earlier, our sites really need a lot of work very quickly. It's not great experience for patients to be treated in our buildings, even though the care might be great. And it's not fantastic working experience for our staff to be in some of the environments that they work in. So there is a real imperative for us to move as quickly as we can. So I have heard nothing that suggests that we would look at Clear Sites. We are really full steam ahead to deliver a model of care that spans 3 sites, but as we said at the beginning, and as both Andy and Claire have backed up, is really around 3 sites having a unique purpose and doing something a little bit different from each other. So that's really all I can say in answer to that. I'm just going to check to see other questions that have come in. There is a question about long COVID, Andy, so we do have to wrap up very soon. So if you can give a very quick answer to how do you see the supporting of people with long COVID going forward, and then we will have to finish.
Clearly, I think it's important. There has been some recent commissioning by Herts Valley CCG and our community partner CRCH have been commissioned to provide a long COVID service in the community for patients that have ongoing symptoms and signs following their infection. I see that as slightly separate from perhaps the sicker cohort patients that were admitted to hospital, and they are already in our follow-up program and undergoing complex cardiorespiratory diagnostics to identify what the problems are and help us try and fix them. So it's two-stranded model, very important, and it's ongoing.
Thank you very much. So that's been a really fascinating session. Thank you very much for all the questions. Really great questions. Thank you. And thank you to Dr. Andy Barlow and Claire Parker for being with us this evening. Thank you also for joining us. Tomorrow is the last one. So if you want to continue right to the very end, please join me tomorrow at 6 o'clock. And if you do have time to look at any of the information on the website, and importantly, please do that survey, we would be very grateful. Thank you very much.